Hello, this is Derek Hansen for StrengthPowerSpeed.com, and this is our 20th episode of our Performance Concepts Chat. And in this episode, I speak with Rob Panariello. I had a chance to spend about 5 days with Rob in New York, and we also attended a workshop that I was kind of leading for a great group of coaches and physical therapists, and it was all organized by Bill Hartman of iFast and also helped by Doug Kashigian of Resilient. And it was just a great environment for a bunch of people to get together. I did a bit of coaching, other people jumped in and provided some input. We had 3 fabulous athletes to work with, and then we spent a lot of time in the day just kind of going over different scenarios and talking about training and rehab too. But I had a chance to sit down with Rob Panariello, who's a good friend of mine, known him pretty much now about 15 years, and somebody I look up to, somebody I seek for advice on all aspects of training, rehab especially, business, and just life, just a good person to lean on. And I highly recommend that after you watch this, I'm sure you're going to get a lot out of it, but somebody you should contact if you haven't, somebody you should visit, and he's a very busy guy, but he'll always take the time to talk to you and answer your email. So we talk specifically about this connection between what happens on the training side and what happens on the rehab side, and especially in organizations, sometimes that doesn't gel together. And Rob has worked in both areas and continues to. And I think for him, it's an easy fit, but we don't always see that happening at an organizational level, and for whatever reason. So we get into the ins and outs of the whys and how things can be rectified. But for the most part, it's really about working with people and learning how to get along, and then getting into the technical discussions, which Rob is exceptional at. So I really hope you enjoy this episode. I think you're going to get a lot out of it. We spent a good amount of time talking. This is a little longer, but I think it's worth it. So have a listen and enjoy Rob Panariello. So Rob, we're out here at a really nice place, one of your sort of vacation spot, and we were involved in an event just yesterday with a good group of people. I would say predominantly strength coaches, but there are also some physical therapists there, and some physical therapists who are doing a lot of the performance work as well. So it's not just strength coach, physical therapist. There seems to be this trend to want to combine the two skill sets. Now, this is something you were involved in a very early time, and it's not anything new for you. But would you like to go back and kind of, reflect on how you got involved in both sides of those things, and then we'll get into some more specific areas.
Sure. So as you know, I'm a physical therapist, and I'm an athletic trainer and strength and conditioning coach, and I've held the position of head strength and conditioning coach at a D1 university at St. John's University, and for 2 professional teams, a football team and a soccer team. And I spent a lot of time with Coach Parker, Johnny Parker, in the off seasons during his time at the New York Giants from around 1984 to 91, 92, all those off seasons. And it really intrigued me. I was never a competitive weightlifter, but I liked working out. And as a physical therapist, what really I think struck home with me was we were rehabbing a lot of ACLs, and we were doing a lot of isokinetic work, doing knee extensions, and a lot of our patients were getting patellofemoral pain. Now back then, and this was 1984, 85, they were casted. It's a different protocol in regards to the post-op, etc. Getting their motion back, they were stiffer. All the things that you don't find today. Vast improvements nowadays, both in surgery and rehab. And so I went to our team doctors, the physicians at our hospital, who were the team doctors for the New York Giants at the time, Dr. Russell Warren and Dr. Tom Wikowitz, and I said, why wouldn't we squat our people? And they were professional enough and objective enough to listen to what I had to say, and we started squatting our ACLs, and this is in '86. And they did very well, and a lot of the problems we had doing knee extensions went away, though every exercise carries its own venue of problems. And so with rehab, if you think about it, a lot of rehab is exercise, right? And then I started to think, well, if the certain exercises make the strongest, most powerful, and fastest athletes in the world, you know, we're pretty bright people in the medical community, I would hope, and whether you're an athletic trainer, physical therapist, physician, chiropractor, whatever, couldn't we take these exercises and adapt them in the rehab setting? And if we couldn't take the specific exercise, certainly we could modify it. And then on the strength and conditioning side, once someone went through a surgery and a rehabilitation with the physical therapy background and the medical background, then we knew the things that we should avoid so not to exacerbate the condition. And so very early, you know, in the 1980s, early 80s, mid 80s is when I just started to bridge this gap in my own mind with the leadership and advice of surgeons, physical therapists, strength coaches of how to do both, you know, how to adapt strength and conditioning in the rehab setting, and as well as take the principles of rehab to avoid exacerbation while training athletes. So really that's how it started.
And would you say you had to go to individuals who were experts in their specific field? There wasn't anybody who was doing that. You kind of had to pull everything together yourself.
The only guy I knew that really had somewhat of a background doing that was a gentleman who I met in 1984, and we've been good friends over 30 years, is Don Chu.
Okay.
Because he's a physical therapist, athletic trainer, and was a strength and conditioning coach, and was a track and field coach as well. So he had the background, and so I learned a lot from Don. My meeting with the Giants, when I spoke to Dr. Warren in the story I just told you, he said, you know, we just hired a new strength coach for the Giants named Johnny Parker, who's big into squatting. Why don't you speak to him, and you may get ideas about squatting from him. And so it was just visiting and doing the legwork, whether reviewing literature, visiting people, picking up the phone and calling, and evolving, you know, a methodology of combining these two professions.
And as far as you know, I mean, at least back then, when people are going, say we look at the 80s, 90s, and even now, when people are going through physical therapy school, how much exposure do they get to, I would say, advanced strength training or performance training?
I don't think they get much, if anything. You know, the focus is on the profession that they're in. I don't know if you condemn somebody for that, right? Because the programs are to prepare physical therapists or athletic training, you know, for their certifications or their licensures. I think there's very few programs in regards to whether it's masters or doctorates in strength and conditioning. I think there could be more on that end of it. But I think once the physical therapist gets out, if they're going to specialize in the field of sports medicine, they don't have to be a strength coach, but they should have a familiarity with what the athletes need to do to prepare to play. And I think that would help assist, that understanding would help assist through the rehab process, so the athlete is better prepared once they return to practice, once they return to training, or whatever the scenario may be at the completion of their rehabilitation.
And they should feel comfortable to go into a weight room environment, go on the field, and understand why certain things are being prescribed.
Yes.
Yeah.
And I think that is a big void in the rehab profession today. I think it's better. But I think it is like anything else, there could always be improvement with the masses. You know, I know some individuals that have gone and succeeded in doing those things, and it is getting more popular, which is a good thing, right? But I think you don't have to be able to coach things, but I think you have to be able to understand the reasoning of why something is done.
And does that, I mean, would you think that should extend to maybe the doctor side, the medical side, the surgeon side? I mean, you have great relationships with a lot of, you know, very prominent surgeons, doctors. How are those conversations when you talk about what the demands are from a physical training side? Are they very receptive in most cases?
They are, and I think it really comes down to your relationship. You know, if you've known someone for 30 years, it's easy to sit down, and if you've worked with their patients for, you know, that period of time or an extended period of time, and you've had good results, they're more apt to listen to you, right? And so the reason why it's a conversation, obviously, is that they are going to bring up points that we never thought of, and you say, you know, I really thought this would be appropriate in this scenario, but it really isn't. Okay. But through this discussion, we realized that there's a scenario that maybe we hadn't even thought of where this conversation is more appropriate. And so really I think that comes down to relationships. I think just like you would see your physician and have confidence in them taking care of you or doing surgery, if they have confidence in your ability to rehabilitate an individual, then it's an open door of conversation. I think by far most medical professionals are open to those conversations.
Okay.
In my experience.
Okay. And go ahead, sir.
Now, and I will just say one thing, and I'm not saying this is right, and I'm not saying this is wrong. I'm just saying, fortunately, unfortunately, this is the way it is. As a strength and conditioning coach, because I am an athletic trainer and a physical therapist, I think that venue of communication has been easier for me based on having those credentials in that background. Sure. Versus if I was solely credentialed as a strength and conditioning coach.
So if you go and do a talk to physical therapist and your topic is strength training, it's going to go over much better than if it's a strength coach coming in, for the most part.
My anticipation in the stories I have heard in some scenarios, yes, because there could be an opinion where you're not understanding what I do, and so you know, what you're saying doesn't make sense to me. But the reality is that, to me, it's two separate professions, each one with their own area of expertise, and what's the word I'm looking for? You know, area of licensure or restrictions as well. And so if the head trainer or the physical therapist and the strength coach all work together, obviously there has to be someone in charge, right? Whether it's the medical team, meaning the team physician or whatever. But the bottom line is what's best for the athlete. I don't think there are many head athletic trainers, and this is my opinion, and you know what they say about opinions, but I don't think there are many head athletic trainers that really want to be the head strength coach. No. And I don't think there are many head strength coaches that want to be the head athletic trainer. And I think there is an overlap of knowledge that both can share and utilize together. I don't think weekend courses make anybody expert, so I don't think there's a lot of strength coaches that have ever rehabbed the post-operative day one condition unless they also had a dual credential as an athletic trainer or physical therapist, and so they shouldn't feel like they could take care of those things, because in reality they haven't been trained to do so. Just like most athletic trainers and most physical therapists probably have not written a periodization program and taken someone through and taught them the Olympic lifts and those types of scenarios. And there's nothing wrong with that. It's just sticking to the strengths of your expertise and your practice act, right? So I think there's a lot to be gained from each professional. And if the bottom line is what's best for the athlete, then if no one wants each other's job, I don't see why there should be a concern of a good harmonious relationship together.
Yeah, I know, and it's interesting. Both of us presented at the 2015 NFL Combine. I can't remember if you presented before me, but I was definitely feeling very insecure presenting to the Professional Football Association's athletic trainers, right? So it's all medical people, and I'm just like, they're not going to listen to me. But at least I had you there. I think you presented before me, so I felt a little more secure that you could kind of bridge that gap. I mean, what was your take on that? It was interesting, though. Brian Engel from the Packers actually emailed me last week and said, "Oh, could you send your presentation through again?"
Yeah,
so at least it's 2 years later.
Yeah, I think there's a thirst for knowledge with that. I think that it has evolved. In my experiences, I do go around the country and I visit some places. In my experiences, there are situations where things may be a little territorial. And I think if that is the instance, then that is the reasoning. I think most medical professionals and strength and conditioning professionals do want to improve their abilities and do want to learn. And I just think that, especially if someone's just across the hall from you,
sure, with
another expertise in a field that you are not so familiar with, or and not at the level of the person across the hall, and it's a two-way street, right? The strength and conditioning professional can learn more about rehabilitation, and not that they're going to do the rehab, but understand the limitations and the modifications to make with these athletes coming out of the training room, so that there is a more smooth conversation, between the two parties, and it's both ways.
Do you have any advice on maybe what would be a good way to facilitate that?
Yeah, I just think that you just have to sit down and seek out individuals. If you're in a situation where you're a physical therapist and you work in a hospital setting or a private practice, seek out individuals in the field of strength and conditioning that are reputable, and that you know, just have the discussion. I think if you're working in a team setting, whether at the high school, college, or professional level, most teams at this point in time, or most institutions, do have both parties. So, you know, have that discussion and just learn from each other. And I know sometimes politics gets in the way, just like any scenario, right? But I think you can overcome that if you really want to enhance your abilities as a professional, regardless of the field you're in, and really remember to take a step back and saying, this isn't about me, this is about the athlete and what's best for the athlete.
And you're a very busy guy on many levels. Now, when you have young people come on board with your company, and there is a bit of a mentorship component, what do you see as the things that they need to work on? If whether they're a performance person working for you or they're a physical therapist, are there things that you advise them, like, hey, I think you should do this?
Yeah, I think they have this. They need experience, right? And with that, they should be mentored by someone because they don't have the answers. You know, I remember coming out of school, I mean, I still don't know more than I do know, right? And I'm doing this 37 years. And so they do need mentorship, and it's not just in the X's and the O's, or the, you know, the mobilizations, or how to write a program. It's about how to handle people, right? Johnny Parker has a good saying: you don't train the weights, you train the athletes, you train the people. And so there's social skills that are to be learned, as well as clinical or weight room techniques or techniques on the track. And social skills are a key entity in regard, because you will be challenged, and to learn how to deal with athletes, and you know that. But
and even there's cases where I've heard that the strength coaches do not even talk to the athletic trainers and the medical side. Like, there's no dialogue, and at that point, when it gets to be that bad, I mean, whose responsibility is to make sure that does happen, or how would you know?
Well, I think two things. I think who's ever in charge is in charge, right? Whoever that person is. And so if you want a harmonious relationship between your staff, then you have to set the example and the precedent, right? If that's not occurring and someone really wants to make those efforts, then they should try to make those efforts.
Even on an individual basis.
Even on an individual basis. And so going back to the young therapist or the young strength coach, I think you go through seminars, you go through, there's a lot of stuff on the internet. Some of it is, there's an old saying, everybody could have their own opinion, but not everybody can have their own facts. So a lot of things on the internet do not have substance. And you determine, what has substance, what doesn't have substance. And you take that path, and then gradually maybe you don't need to take as many courses versus going to speak to the individuals, and that's what I did. I'm not telling you you have to do it my way, but back when I started, there was no internet, there was no social media, there was the telephone and visiting people. So I go back to, first met Don Chu, went to see Johnny Parker through Don Chu.
And you traveled, you physically traveled.
I physically traveled, yeah. I mean, I went to, in '87, I went to the Soviet Union in East Germany, because I wanted to learn the techniques to be the best strength coach I could be. And then in '88, I went to Bulgaria. I wasn't a very wealthy individual, right? So, so I forfeit my vacation for that year for education.
Yeah.
That's a decision I made. If someone else didn't make the same decision, that's okay. But that's just what I wanted to do. I happened to be at a hospital called the Hospital for Special Surgery in New York City, which, in my biased opinion, admittingly, is the best institution for medicine and orthopedics and sports in the country, if not one of the best in the world. And I had physicians like I mentioned, Russ Warren, Tom Wikowitz, Dave Olchek, Steve O'Brien, Answorth Allen, a number of so many physicians that too many to name, and I learned about academia through them, because it's a very academic institution. So then I started publishing papers, and you publish papers, and you start to get on the speaking circuit, because people want to know what this research is in regards to bridging the gap between strength and conditioning and rehab. Why you're doing these things, and you meet people like Kevin Wilk, Russell Payne, and so many other physical therapists who, again, it's a long road, right? You've been friends with for 25, 30 years, as well as my partners. Some of my partners are excellent physical therapists. And then, you know, from Don to Johnny to Al Vermeil, and then Don Chu and Al Vermeil both know Al Miller, and you know, it goes on to the young guys I know now who are outstanding strength coaches in my mind, like a David Feely at Temple, a Brendan Ziegler at Cal State Bakersfield, you know, Clete McLeod at Nebraska, you know, Tim Rabis at North Carolina State, and there's, you know, again, just so many too many to mention. Sal Alosi at UCLA. I just went blank. You know me with names.
Or
Ryan Reynolds at the Kansas City Chiefs. And just, you know, and these people are the key is all these individuals. And what I learned in special surgery is they're lifelong learners. You know, you just never stop learning. And if you do that, then you're going to go to individuals regardless of their profession to learn. Al Vermeil, and you know this, Al Vermeil for about 20 years used to bring in individuals from Carmelo Bosco to orthopedic surgeons to physical therapists to strength coaches, exercise physiologists from around the world, and that's why Al is just a brilliant strength coach. He brought in the people. He would videotape them when they were there for days or weeks, whatever it was, and he has this whole library of all these individuals of world-renowned
most of whom aren't around anymore.
Also aren't around anymore, but he learned from them.
Yeah.
Plus his own travels, and so, you know, between the doctors at special surgery, people like Al Vermeil, and you know, you just learn to become a lifelong learner. You do, and that's critical. Yeah. In my opinion.
I know the first time I talked to you was in about 2003, and Al says you got to talk to Rob about ACLs, and I think I might have had 2 or 3 that I had been involved with. And so I talked to you. Now I have 18,000 cases that you know, I can, you know, access through you of how, you know, it could go. And I think that was a big awakening for me, is understanding that, wow, by expanding my network, I now have more data.
Absolutely.
That is actionable to some degree.
You're never going to live long enough to make all the mistakes that need to be made, so you need to speak to the people that have made the mistakes so you don't make the same ones, you know, and that's a big benefit of the relationships with people. You know, this is what worked and this didn't work. And there's nothing wrong with saying, I don't know, and there's nothing wrong with saying, I wouldn't do this because when I did this, it didn't work for me. I made a mistake. That's how we learn. Just don't make the same mistake twice. Yeah,
now if we get into the specifics of something like an ACL or anything to do with the knee, and you're my go-to guy, obviously. I mean, what are some of the things that strength coaches should know when dealing with somebody who has a knee issue or is coming off of surgery? Because I think a lot of people feel insecure. They may feel like they're outside of their scope. But what can a strength coach do to make that a positive situation?
Well, in some scenarios, they are outside of their scope, yes, right? Because they're not a medical professional in that aspect, okay? They're part of a team working with the athlete, which is a critical component, right? Because they're the strength coach is the last component before they're on the field to play, before it's showtime. Yeah. And so they are a critical component of this team. And I think they have to be familiar with, sit down in this relationship, whether it's a team physician, the team trainer. If that happens to be the head trainer, so be it. If the head trainer should be there, so be it. And if it's an assistant strength coach, maybe the head strength coach needs to be there for guidance, whatever it may be. What was the surgery? What was done? Just so there's an understanding. What was involved with the rehabilitation? What is their medical history? What are the precautions that we need to review? What are any problems at all that went along with the rehab process? And then from the strength and conditioning perspective, okay, the person has never run before and we need to get them running, or they've never thrown before, they have shoulder surgery. We'll just say that. Maybe they give their opinion, this is how I work with my healthy athletes. This is the progression I use. And the medical team may say, I never thought of that progression before. That's great with the exception of this part. Let's just modify it. And that's just working together. And I think that's what needs to happen. I don't think the person just walks into the weight room or on the track and says, I'm done with rehab, get me going. Because you don't know what the precautions are. You don't know what the modifications that may need to be made unless a discussion is had. So let's have the discussion.
Mm-hmm. Yeah, and you know, obviously that's sometimes very difficult for people to maybe let down their guard and say like, hey, you know, what how can I help, or what can you offer me to further my education? Now, one
more thing. I think another thing the strength coach offers is that I think in the rehab profession, and again, this is my opinion, whether I'm right or wrong, it's my opinion, we're afraid to load, right? I don't think we sprint enough at the time that someone is able to start sprinting. I don't think we load with intensities that the patient is able to tolerate, because we're always on the conservative side. And I'm not saying overstep that proverbial line, but when you're going to play a sport like football or lacrosse or rugby or soccer, it's a very physical game. There's physical contact with individuals who are very strong, very powerful, very fast. And so to be a little too conservative for the concern of, I don't want to put that knee or that shoulder at risk, or that back, whatever, when they're on that field of play and they have such a physical deficit in regards to strength, power, speed, they are predisposed to injury in a different environment, right? And so we load our athletes in the weight room, whether it's jump heights, whether it's loads on a bar, whether it's velocities on a track. We load our athletes at high levels because that is the standard that's necessary to play the game. There has to be some type of progression with, again, I repeat, you never put anybody at risk. But we try to get as close to the proverbial line without crossing that line with intensity, because the further they are ahead through the rehab process, then the further they're going to be to the type of training that needs to occur to prepare them to play the game. And I think that's something the strength coach also offers. You can't say they need to lift X to play the game, but we're not going to load them. And this is the progression we do to have them at this strength level. These are the drills we do to get them running and sprinting at high velocities. And the medical profession, who's not trained in that area, being educated, and they may say, hey, that's a great idea, just like squatting our ACLs back in 1986. Everything we do, and I've always believed this, just based on my background, I'm a very academic person because of the route I took in my training. And so everything we do has to be based on science. And the reason why I say that is this. Like I said before, everybody have their own opinion, but you can't have your own facts. If you don't know why something works, how do you know it's appropriate for your athlete? Whether it's in the rehab setting, whether it's in training. Now let's say Derek Hansen does a certain drill. I don't know what it is. I don't know how it works, but I'm going to try it. And so I get lucky. I mimic your drill and my athlete improves. Well, if I don't know how this drill works, how am I going to progress it? Right? You can't. And so you've got to have this. So the science is there. What am I trying to do? What is proven why this works? Now the other part, as you know, whether it's doing surgery, doing rehab, or especially coaching, is art, right? So, well, we're going to load. Well, how much? How often? This is the modification we're going to make. Why? Okay, I'm not familiar. This is what we need to do as a medical professional. If there's only a way we can modify this exercise, it would be safe to perform. And then the strength coach says, well, I never realized this exercise would need to be modified for this pathology or this case, but we have a piece of equipment, or we do this all the time, which is a modification of that exercise. And the medical professional says, great, let's do it. And that's what I'm talking about. It's just communication, and then based on science. You have to base what you do on science, but it's also a lot of art, as you know.
Yeah, because even, I mean, in art, if you talk to anybody who's involved in music, I mean, there's a huge mathematical component behind music.
Right. Does that sound right?
Yeah.
That's not science. The science is, you know, this is how you make the strings, right? And this is how you make the strings sound right. And this is the tension that performs this, but the sound is art, right?
Yeah.
The stroke is art.
Yeah.
You know, so
but I'm sure for any artist, they're operating within certain, if they probably don't want to use this word, but they're operating within certain rules of their art. And they don't deviate too far outside, because a painting will look like crap if the colors are wrong, and a song will sound like crap if you're not in the right key. So,
but it's okay to deviate out. It's okay to color outside the lines. That's how we progress, right?
Yeah.
So we don't write with ink pens as much. We use computers. I mean, we've progressed. We have the Pony Express. We have FedEx now, right? So we've progressed, but the progression is based on fact and validity, right?
Yeah.
If we're going to enhance a surgical technique, it's got to be based on what we know about soft tissue and the instrumentation and how things work. And surgeries continue to evolve, but it's not let's throw darts at a dartboard and try that, right? Yeah. So if you take an artist, right, when they combine two colors, the result is always going to be the same color, right? Yes. That's fact.
Yes.
Right? That resulting color, whatever it may be.
And there's probably a science behind it.
Yeah, there's science behind it, but that resulting color, whatever it may be, where am I putting it? How much am I putting on? Yeah. And the brush stroke that's the art, right?
Yes.
So even artists, right? They've got to deal with science and fact, as well as obviously artists, the art. So
now, if we talk about this gray area of like what is acceptable, what works together, and a lot of the time, we had a chance to work with a young man yesterday who was 4 months out from an ACL surgery, and this was the first time he was going to sprint. There were certain things that we were, certain questions we had about what was appropriate. But if you have somebody who is just progressing very well, how rigid do these timelines have to be? Like I was always told, like you have to wait at least 12 weeks before you can do any significant loading for somebody coming off an ACL.
Yeah. It's dependent. It's dependent upon the young man yesterday was a second surgery, right? So that's different than one surgery. So I would always be more conservative on a second surgery of the same knee with the same condition, 2 ACLs, 2 whatever. There is a tissue healing continuum, right? And there's different stages that tissue heal, and we only turn the clock ahead an hour a year, so you do have to wait for the time for biology to take its course. All right. Now, biology will react positively to appropriate levels of stress. Again, the art, right? Yep. But knowing how much stress and the type of stress and where to apply the stress, the science. So, depending on the injury, if there's any concomitant damage, right? So is it an ACL? Is there an ACL with a posterior horn of the meniscus? Is there an osteochondral lesion? What's going on there, or is it just a straight ACL? And the healing effect, the graft that was used to repair that, was it a central third patella tendon? Was it a hamstring? Was it a quad tendon? Was it an allograft? Because how evasive were we the surgeon, in the type of surgery that was performed, and then individuals, right? Some people are going to run sub 10 second 100 meters. Some people will never come close. They just didn't pick their parents well. And so a lot of it is, in my opinion, is dependent upon this healing continuum in conjunction with how strong they get, because with strength you get stability. And I just go, if you want to go by simple rules, 2 legs before 1 leg, low velocity before high velocity, linear before change of direction. And it's like anything else. If you're going to teach somebody exercise, like in our rehab for lower extremities, even upper extremities, we'll have our athletes do pulls from blocks. Not very technically proficient, right? Not difficult. You just have to teach someone to pull. Don't use heavy weights, but we do that because of the science of the rate of force production. And we know that rate of force production, it's a tough thing. Power and elastic abilities are the last things that come back, right? Strength comes first and the rest of it come back later on. And so we try to get an early kickstart on rate of force production by doing various drills or various exercises that are low in regards to taxing the injured area, but also helps enhance rate of force production. And as you go through this process, so you may say, okay, I'm going to do box jumps. Because when you jump up, jumping is a high velocity activity, but when I land on a box of a height that's higher than the ground area, right? The impact is less because I haven't traveled the same distance to return to the ground.
Mm-hmm.
So if you jump up to a 2-foot box, it's not as much impact as jumping in place,
Mm-hmm.
but it's explosive.
Yep.
So you might do jumps, you may do pulls, and then you actually start doing Olympic lifts, and then you start at the same time, you want to go linearly. We'll talk about the drills that you went over yesterday. A walk,
Mm-hmm.
low level A skips,
Mm-hmm.
a higher knee A skips,
Mm-hmm.
A runs,
Mm-hmm.
and then you're running again. So you're working rate of force development in two scenarios, but one's more specific to running, but it's low impact with the walking, right? But the mechanics is starting to come in. But you wouldn't know that unless you were in the field of strength and conditioning as a
Sure.
rehab specialist.
Sure. And there's this double-edged sword of, if I, you talked about rates of tissue healing, and it's difficult because if you don't apply a stress, it may prolong that tissue healing. Whereas some people may think if you stress them, oh, you're rushing them, you're putting too much stress on too early, but that stress is required.
It is, and there's stress required in everyday living, right? So if someone said, I don't want this individual squatting, but they can sit in and out of a chair, what's the difference? Well, I'm afraid you're going to put 400 pounds on their back. Well, why would I ever put 400 pounds on their back? You know what I mean?
Yeah.
I'm being facetious,
Sure.
but if they're getting in and out of a car, they're doing single leg squats if it's their left leg, right?
Yeah.
And so, they are stressing the leg. And that, again, that's the talent. When to stress the leg, with what exercise, at what intensity, at what volume, at what frequency. And then generally what happens a lot, at least in the rehabilitation, we don't unload very often. We just keep going in a straight line. So what happens? We had an exercise or two, a lightweight, let's say they do 3 sets of 10. That's the norm, traditional, right? So they do 3 sets of 10. Then what do? We add more exercises.
Yep.
But as we add more difficult exercises, and in my experience, especially with the younger therapists, they don't take anything off the back end. So volumes continue to climb.
Yeah.
It's always 3 sets of 10.
Yep.
And the only thing that changes is the addition of exercise and the addition of weight. Where's unloading?
Yep.
And so eventually there may be a point in time where someone breaks down. And, I think that there's a point in time where, and again, it's an art. There's a certain number of exercises they need to do. I mean, if they're 12 weeks post-op and they're still running, do they still need to do a straight leg raise with a 5-pound weight or 10?
Mm-hmm.
Yeah, I don't think so.
Yeah.
And that's my opinion. Someone else may argue that they do and maybe justified in that argument. I don't think so. So I think there's a point in time where you add a certain volume of work, and then as you enhance the progression, you take away from the simple side, the easier stuff, so that your volume is pretty consistent, but the quality of work, meaning intensity, velocities, is continually improving, giving you less chance of overtraining, because you could overtrain in rehab too, because it's just exercise.
Yep.
We've talked about that. To me, training an athlete in rehab is have a lot of similarities, right? Because
Yeah.
it's exercise performance.
You're trying to create an adaptation.
Yeah.
A positive adaptation.
Now there's soft tissue and mobilizations and modality. I acknowledge that. But there is a significant component which is exercise, and it's very similar to training.
Mm-hmm. Mm-hmm. And it's interesting you talked about, this idea that, well, we're going to squat with somebody, and the assumption is it's going to be some ridiculous weight, and weightlifting is bad. And I go through this with even my kids. Like, I'm introducing them to weightlifting. People are like, oh, that's too much. And it's like, well, we're just using the bar, right? So
Yep.
it's just, there's a progression. And I think the same happens with sprinting. If you say sprinting, right away people think it's 100% sprinting max out, but there can be levels of it sprinting,
Absolutely.
right? And I think
It's like anything else. You don't start, you know me, I'm not the most IT savvy guy, right? But when you start a computer program, you're at 101.
Yep.
You're not using the most advanced computer system the day you sit down and first start using a computer. With math, it's math 100, not math 500 when you're a freshman in college.
Yep.
And so it's the same thing. It's the same thing with exercise. I'll go back to a simple exercise like a straight leg raise, right? So can they do it just by lifting their own limb? And then we're going to add light weights. Who's going from lifting their own limb to 10 pounds? Or who's teaching someone to squat with a bar, and then the next step is 300 pounds. It's the same progression you would in any other scenario in life, right?
Yeah. And when you have somebody who, I mean, if there's different rates of improvement, and you have somebody who's doing really well, so say you take them out and they do the sprint drills and do some accelerations, like, do you have a sense of when to cut people off and say, look, that's enough? I've seen, like, you've gone here to here, that's good. Is it difficult sometimes to cut them off even though you're seeing such great improvement? Is that one of those?
Yeah, it is, because I've been burnt a few times. Like I said, I've made my mistakes, and especially in the beginning working with someone, I don't want to do too much, because the analogy I always make is, you go to the gym, you have a great workout, you go home that night, you're relaxed, you wake up the next morning, you can't move. The worst thing you can do is someone feels great with the workout, and the next morning they wake up and their shoulder's killing them, their back is killing them, their knees blown up and swollen. Now you've taken a few steps backward versus progressing them forward. So if you're not sure, I would always err on the side of being a little bit more conservative, because you have the time. You have more treatment sessions. You have more training sessions. So what's the hurry, right? Yeah. Now, as season approaches or the end of your rehab approaches, that's a different scenario, and if you're not sure what to do, then that's where you need your mentor, or you go to your medical professional that you're working with, whatever, and you have the conversation. This is a situation I'm in. I'm not sure what to do. There's nothing wrong with saying I don't know. There's nothing wrong with saying, hey, I made a mistake. Just don't make the same mistake again.
When you present on this type of stuff and the introduction of exercise and complex forms of exercises and loading, when you introduce this concept to other physical therapists, do you sense that there's apprehension? Do you sense that there's people who feel uncomfortable with that?
Yeah, for instance, things I've learned from you and Charlie, is that for enhanced performance, right, recruitment of motor units, the neuromuscular system, muscle fibers, you have to be at an intensity, right, whether it's a jump, a speed, or weight of 90% or better, right? And so what people understand but don't trust is that 90 to 95% is still submaximal.
Yeah.
It's still something that can be done safely. What's dangerous? Inappropriate application, right? Too much frequency. And so someone breaks down because it's not that they couldn't run at 90, 95%. They try to do it that's the art, right? Yeah. So
it's kind of a sweet spot, like that 90 to 95 I find is very, very beneficial without the risk. It's almost like, I always use the golf swing analogy, where nobody's swinging at 100% because it's out of control. It's just risky. But as I get older, I'm thinking that's a really nice place to be.
Yeah. Now that 90 to 95% may not be where the patient was. It may be 99 to 95% of your anticipation of where they are now, right? To just continue to jumpstart. Yeah. And so that's a difference. So a mistake could be made where, you used to squat 300 pounds, so we're going to put 270 on the bar, and that's not right at that time, right? That's 90%. And so where are they? And that's talent, that's the art too. We're not maxing people out as we go through rehab, but the way you look, and maybe it's just experience, the way you look, I think you can do this. And that guesstimate becomes more accurate with more years of experience, just like with coaching, right? You could look at things now where maybe 10 years ago you wouldn't even have seen. It's the same thing.
Yeah, and I mean, when you're teaching people, is that a difficult thing to impart? Because there is an experiential component to it, right? And it's not something that you can just have on a PowerPoint slide and say, like, if you do this, this will happen. There is a trial and error component to the learning. There is this, it's going to take time to understand. Because I know for me, even this past weekend, I just say, well, that's what I see. But that's not an acceptable explanation for some people, because it is very field-based.
Yeah, right? I think if they know why, it solves a lot of problems, right? You don't just tell somebody, I'm going to do this. This is why we're going to do it. This is the reasoning behind, and this is how we're going to progress it for these reasons as well. So I just spoke at a conference, and I talked about taking ACLs, and we go from blocks. Now, this is a guideline, right? Everybody wants to say hard, fast, depending on how the person's progressing. You may not even try this if they're really doing poorly. And some people don't do well, whether they have low pain tolerances, whether there are complications, whatever it may be. But the majority of the people I've worked with at 6 to 8 weeks, based on this healing continuum, based on a position of standing and having compressive loads through the joint, they can pull, the bar 65, 75 pounds from the mid-thigh and start this process of rate of force production at 6 to 8 weeks post-op. All right? Most are appropriate. There are some that won't be. That's the talent, right?
Yep.
So then at 10 weeks or so, 8 to 10 weeks, that range, depending on how you'd started your pull, then we'll start to, again, the talent of the athlete, right? Because some people are very athletic. Then we'll start to teach them how to clean and catch from the mid-thigh, right, with light weights. Again, for the reasoning of not only rate of force production, but that eccentric load. Because in most sports, there's going to be eccentric loading and impact,
Yep.
right? Okay. I had someone ask me, on the catch, do I have a problem with someone's knee bending going down? Now that knee bending going down with a catch of 65, 75 pounds, and maybe heavier depending upon the talent of the athlete, is the same knee angle than when we step downstairs.
Sure.
It's the same knee angle when your foot is underneath you when you're sprinting.
Mm-hmm.
It's very similar. And you know, depending on who you read, it's 6 to 10 times body weight when you're sprinting, impact.
Yeah.
So if you have a concern at 10 weeks of someone catching 65 pounds, how do you expect them to load 6 to 10 times their body weight at 12 weeks when on a lot of these protocols they're supposed to start running? Yeah. And that's the way I look at it. And if they couldn't catch and they couldn't do those things, then how would they possibly be able to run at 12 weeks? They can't, because they can't sustain those loads. They don't have the eccentric strength, they don't have the knee stability, they don't have a lot of those things that are necessary. So maybe this group has to start running, this individual may have to go at 14 or 16 weeks. And you have to pick up the phone, call the doc and say, look, I know you want 12 weeks, it's on your protocol, this is what I'm seeing, and these are the reasons why I think we should delay running.
Yeah.
And it's a conversation, and who would not be receptive to that conversation? Because by having that conversation, you're trying to avoid putting the patient at risk. However, if they could do those things, then why is there a fear of catching 65 or 75 pounds at 10 weeks post-op?
Yeah, yeah. So there's almost what it sounds like is you're saying that the rehab professional or the strength coach has to understand what the end goal is or what the end state is. So if these are the sports requirements, they have to be able to absorb these types of forces. They're here, there has to be an interpolation or at least a linear progression up to there, and it can't be like this, right?
Yeah, no, absolutely. And the example I'll always use is a baseball pitcher, right? So when a baseball pitcher has a labral repair or rotator cuff repair, and let's say they're a major league baseball pitcher, all right?
Yeah.
Comparatively to the non-affected side, or how the physician and the therapist and the strength coach, everybody feels they have great range, they don't have any pain.
Yeah.
They have great range of motion.
Yeah.
They have great strength in that shoulder and the rest of their body. But they could only throw at the major leagues 80 miles an hour. You would never play that pitcher in the game because they haven't met the standards of the game. Yeah. So they would continue to work on their pitching, whether it was mechanics, whether it was just the process to get their velocity back, just like if they were sprinting, right, just a process. And now they're throwing 90 or better a month or 6 weeks later. Yep. Now you'd say they met the standard of the game, and even though everything else was fine, we're going to put them back in the game, and they're going to be effective. What's the difference if it's a knee or a hip or a back or a shoulder? What's the difference if it was baseball, football, soccer, lacrosse, track and field? If you had someone who had a knee surgery and they were going to be an Olympian and they ran 11:0, 100 meters, would you run them in a race? Mm-hmm. You know they're not going to be successful. Yep. You would keep training them until they could hit the times once again where they could be competitive, and that's when they would compete, because they met the standards of the sport or or position they play. What's the difference in rehab or training? So it's not just about the other extremity. It's not just about that comparison, which in the literature shows validity. We also have to look at what is the standard of the game and the position they're playing. In regards to physical qualities, psychological aspect, are they afraid to load the limb? Are they afraid to throw hard because they're afraid to use their shoulder? Those psychological aspects, and I'm not a psychiatrist or psychologist, but it's a factor. And if you have all those things in place, then they're ready to play. Yeah. But if there is such a fear or such a deficit in their abilities, but everything appears to be okay, good motion, the strength is okay compared to the other side, whatever, we're putting them at risk of getting re-injured on the field of play, because as you know, nothing matches the competitiveness and the adrenaline of the day of competition So people are out of their minds that day.
Yep.
And every day in practice, they're competing against their peers who have these standards, right? Have achieved these standards. That's why they're playing. And so every day of the week, they're going to be at a significant deficit unless we bring them back up to those standards, whatever they are: speed, strength, power, throwing ability, whatever it may be.
Now let's assume that there are cases where this is happening, where people are being reinserted and they're not ready. What's going on there? I mean,
I think they're at increased risk of injury, and they're not very effective. So let's say we have a football player that's going to go back and he can only run a 5.040.
yeah,
Who's he going to catch, and who's he going to be able to run away from?
Yeah.
If you have a lineman that can only, and I'll just go back to squatting or something, doesn't have to be squatting, but you have an NFL offensive lineman and their peers are, the defensive linemen are squatting 500-600 pounds and they're squatting 250 to 300. How effective are they going to be? Maybe they can cheat on technique, maybe they're experienced, but after a while, you know, it's all going to come out, right?
But what are the reasons that, what do you think, and again, this is getting into an area where, you know, there's some human qualities here where you have somebody that needs to be here, they're here, and they only get to here, but they're reinserted. Is it a timeline issue? Are there people that don't have the skill sets to get them up here? Is it, you know, what is there fear?
Yeah, I don't know if, I'm not going to comment on somebody's skill set because I know the specific individual. I think there's concern. Like I said, I think there's concern with loading.
Yeah.
And like I said to you before, I think it's easy to understand that 90 to 95% of one's ability is submaximal. It's not an easy thing to trust in application. I don't think people, I think there's a concern with doing that, but it is safe to do, as you know. And I just think that we, in many situations, we restrict the comparison to the other extremity, right? The non-involved is how does it compare to that non-involved extremity? And it does go more, excuse me, it does go more than that. It goes to how they, you know, what do they look like on the field? And I don't think anybody is intentionally putting anybody at risk. I just don't think that enough of us are thinking about where do they compare to the standards of the game versus just a comparison of the other leg or the other shoulder and simply how they look on the field of play.
Do you think they're missing maybe evaluation tools that'll tell them, yes, okay, this guy, you know, maybe they're afraid to test them, but maybe, yes, he can handle this load. We've tested him. Yes, he can run this fast. Yes, he can direction change off of this velocity. Do you think those tests are happening, or do you think maybe they're skating around these things and saying, oh, he looks pretty good. How do you feel?
I think they'll happen with a congruent relationship with the strength and conditioning coach, right? Because here's the process. Injured on the field, the athletic trainer saw them. Physician also saw them. Let's say they needed surgery. Whether they needed surgery or not, they went through a rehab process. They were finished their rehab. They entered training, all right? And through the training program, they were prepared to play, and now they're playing.
Yeah.
I'm not sure if that sequence is as efficient in all scenarios, in my experience. And so that's why my point from the beginning, if everybody's working well together, you'll wind up with that type of product where they'll be fine, they'll meet the standards of the game, everybody's contributing with their expertise, and the person who benefited the most was the athlete, because now they're back playing at the level they were prior to their injury. You know, the other thing I just want to say is, you know, we're speaking as if, you know, this is an epidemic, and I don't know if it is or not. I'm sure there are a lot of people out there that have a system in place where there's congruent communication between all parties. You know, there are a lot of good people out there, and the good ones are the ones we visit, right?
Yeah.
So, you know, they're definitely out there, and a lot of people out there doing a good job. So I don't want to make this like make this like doomsday either, you know.
Please, and if there are people out there doing great things, let me know. We'll get you on. Now, if we talk, you know, we talked about exercise prescription, and obviously lower body can be complicated, but probably not as complicated as some of the things that happen with the shoulder. And I'm pretty fortunate. I've never really had any problems with my shoulder. One of the fellows that I work with, John Abreu, his shoulders are, you know, he's having some issues now where it keeps, you know, kind of slipping out. He'll do something, and he'll say something like, "Oh, I had a really good lift, no problems." Then he'll go out and play like rugby or something and go to reach for somebody, and then it just doesn't feel right. So what kind of things are you guiding people on in terms of what they're doing for training, if they do have some shoulder issues, if they're coming off surgery? What are the complications around that?
Well, first you have to know what the problem is. So they should see the authority, who deals with shoulders. And we'll go back to ACLs for a second.
Yep.
I don't care if you tore your ACL falling down a flight of stairs, or if you tore your ACL getting tackled on the field of play.
Yep.
If you have to have your ACL reconstructed, you go to the people who do the ACL reconstructions, right? And so it's the same thing with the shoulder. So you need to know the playing field. You need to know what's wrong. And then once you have that information, then you'll determine, do they need surgery, type of surgery, how much surgery, concomitant injuries, etc. And then you can set up your rehab program, and they go through rehab. I'm a big advocate of over time, if appropriate. I like overhead pressing. I just think that it's not a dangerous it's not a dangerous exercise if applied appropriately and prescribed appropribody.
Why are there fears around it? Is it just an intuitive thing? Like if I...
Yeah, I just think one thing I'm hearing is everyone's concerned with the grade 3 acromion, right? And so that's true, they exist, right? But we're not going to x-ray everybody or image everybody who's going to go and work out. We have a performance center. We train athletes. All our athletes go overhead. We haven't had problems with going overhead. Professional baseball players, $100 million baseball players, pitchers,
yep.
right? Going just what is the volume, what is the intensity, what is the duration, right? And how frequent. And so grade 3 acromions are in the minority. Most people have a 1 or a 2, so you're okay. If your cuff is working appropriately, if you have the appropriate range of motion, going overhead is a normal function of life, right? Taking a glass off a shelf, etc. If you have poor glenohumeral scapulothoracic neuromuscular kinematics, then you wouldn't do it, right? Just like an exercise, if it's not appropriate, you wouldn't do it. Loads wouldn't be appropriate. Range of motions have to be there. There are people that won't overhead press, but they'll have somebody do lat pull downs or pull-ups. How does that make any sense? We work with a lot of high schools. So usually the quarterback in the fall is a pitcher in the spring.
Okay.
So they can overhead press in the off-season training for football, but because they're a pitcher, they're not allowed to overhead press preparing for their baseball season. So is this exercise dangerous depending upon the time of year?
And where does that come? Where does that come from?
I think it comes from the myth of the squat from years ago.
Yeah.
Carl Klein, people like that. That squatting was dangerous for the knee, and no one exercise is appropriate for everybody, right? Yeah. So squatting definitively may not be appropriate for some individuals, and so you'll have to find that's the talent. What else can I do to strengthen these legs, right? Including sprinting. And so going overhead, I don't believe you'll never tear a pec lifting overhead, but you'll certainly tear your pec, as well as all the concerns of that grade 3 acromion, tendonitis, torn cuffs, things like that. Happens bench pressing too, right? And bench pressing, you will tear a pec, but you'll never tear a pec going overhead. The kinematics have to be there. There's a lot of advantages to going overhead. You're on your feet. That's the way you play the game, etc., etc., etc. When do I select this exercise? When it's appropriate. How do I incorporate it? Appropriately. That's the art. But lifting overhead, I don't find any problems with it in appropriate conditions. But shoulders and knees and ankles, it's the same thing, right? You have this generic prescription, right?
Yep.
So you're going to find certain generic guidelines. What are they? Pain, edema, restore motion, restore, I hate the word function, but restore their abilities or their function. And then you have, I go by Al Vermeil's hierarchy, right? You can train various physical qualities at the same time, but your emphasis has to be placed on the needs. And once those needs are fulfilled, then you progress to the next set of goals, right? And you need to establish strength, and then power, then elastic abilities, and then speed. And think of it as strength. If you can't apply force, power having a velocity component, well, then how are you going to apply force quickly if you can't even apply force? You need to establish movement, things like that. But there are basic premises for all conditions, from the healing continuum to, like I said, pain, edema, movement, strength, power, etc. The specificity comes into type of injury, type of surgery, the joint, patient's sport of participation. If they don't participate in a sport, what is it their level of function? I could have a 75-year-old male or female that all they want to do is walk. Do I have to worry about doing plyometrics with them when they have a total knee replacement? Of course not. But they have to be strong enough to be able to withstand that distance and have a work capacity to be able to withstand that distance. Or if they want to play golf once or twice a week, then they have to withstand those stresses and what are the standards that we need to meet so that they can do those things. But they're not going to go out and do sprinting activities and like a young athlete would. And so a lot of it is really is precedent on what's presented in front of you. And that's another weakness I think we have in both professions, strength and conditioning and rehabilitation. And not to be so critical, but it's usually the younger professionals because they haven't had the experiences enough to have a good ability to critically think. They say they follow the protocol to a T instead of standing back and say, well, wait a minute, this person isn't strong enough. Excuse me, this person isn't strong enough to start training elastic abilities.
Yep.
Right? So I need to enhance their strength a little bit longer and tell the doctor that because this is strength role in being elastic, right? Whether it's muscle and joint stiffness, the stretch shortening cycle, all that stuff. They need to be able to look and critically think. The same way you can look at someone running at high speed and see at a certain point in time their hip dropped, where no one else would see that, right? But you would because you have these years of experience. And you'd say, at that point in time, at this distance, at that velocity, their hips dropping, and we have to correct that. And that's the ability to critically think instead of saying, okay, at this yardage, how do I keep getting them faster, faster, faster? You know, you can pick up the problem versus how do I just keep training them to get faster, right? And that's critical thinking to me. And that, again, is based on both science and art, but most likely experience and having a mentor. But I really believe that the younger professionals, whether we can, as a mentor, try to teach that. And if you don't have, if a young professional doesn't have a mentor, I would find someone. They don't have the ability to critically think. They seem to follow A to B to C to D, and sometimes it doesn't matter what period of time it is. It doesn't matter, you know, what they've been through and what you want to achieve, right? It's not just going a straight path. It's going back and forth and being able to devise a plan based on what's put in front of you, not the plan that's put in front of you. You know what I mean? So critically thinking is imperative, and I think it's a weakness.
Yeah, and I think that in this day and age, it's very instant gratification oriented, and I can get some information off of the social media video or just, you know, very short burst of information that has no context. Whereas in even what we're doing here, if I'm talking to you for about an hour and a half, it's just a starting point for somebody to reach out and try to talk to you more, and or else reach out to somebody else in the same area. And I think that's maybe what we're missing, is that personal connection and mentorship that's lacking now.
Yeah. So to go back, if you're a young athletic trainer and you're starting at a university, a college setting, and you're young, you don't have a lot of experience, and you have this athlete that had a lower extremity injury or surgery, and you have to bring them back to running abilities, why wouldn't you go to the track coach or go to the strength and conditioning coach and say, what are the running drills you use from most remedial to most complex? And look at these things from these professionals of a different field, all right, of expertise, and say, those are great ideas. I can adapt them in my rehab setting because I haven't rehabbed that many people, and I got to get this person running, as well as go to your superiors in the department, you know, your head trainer or your head therapist, or it may be, and get their ideas of what went on. And that's all I'm saying, this whole premise, right? So everybody can contribute. The head track coach does not want to be the assistant athletic trainer, right? And so, and then when the head track coach says, I don't understand why this person isn't competing at this time, you can't say, well, they can't because they just had surgery. I think they're entitled to, as the head coach, an explanation detailed enough that makes sense why this athlete can't participate at this time, you know?
Well, there's a bit of a do-it-yourself mentality these days, and I was talking to you about doing home repairs and just figuring out how to do it myself. But the track coach example is interesting because there's track coaches that I know who are very competent, and they, in a college setting, they will be given a strength coach who has no background in track and field, and they find it very difficult to work with that strength coach because that strength coach may not understand their sport or their process, and I think maybe there's some insecurity there sometimes, or trust issues.
Yep.
So, I think it does come back to what you said, though, is people have to kind of open up, let their guard down a bit, have the discussion, and then, maybe start from a place where everybody's comfortable, and then grow the relationship.
Right, and I understand that uncomfortableness, or that the desire to earn trust, right? Because that's normal, right? I don't know you. You've just meeting you today. How do I know? But if you sit down and have the conversation and you say, this is what I expect of my athletes, how are you going to get them there, and not get defensive and say, this is what I've done in the past, this is what has worked for me, this is my intention. The track coach may like some of your ideas, may not, but if they don't like some of the ideas, they should be able to give, or any coach, right? They should be able to give justifiable reasonings, not just because I don't like it, it's not the way I've done it. Well, we don't do things from the 1950s anymore either, right? Hopefully. So that's not a reason. A justifiable, logical reason with validity. And now you're educating the strength coach in a point of view that they never occurred to them because it's new to them, right? And now you're developing a working relationship. Okay, and a working relationship is give and take, right? It's not right here, right? This is it, this way we're doing it and that's it. But, as a strength coach, you have your job, you have to work with these coaches, and the head coach also should understand the strength coach's role and contribute to their knowledge as well. Mm-hmm. And then, the strength coach will take from the track and field coach, this is how I progress my running. This is how the new running drills I've used. This works very well. And guess who he's having or she's having that conversation with? The trainer or the physical therapist, when they're talking about return to play and starting running when it's a first year brand new athletic trainer that's never had somebody return to running before. And so maybe that conversation also happens with their superior because they're young. But this is where everybody fed up each other. And the thing I go back to is the head strength coach doesn't want to be the head track coach. The head track coach doesn't want to be the assistant trainer. And the head trainer doesn't want to be the head strength coach, usually, right? Mm. And so I don't understand, with the exception of if someone wants to be territorial, why there isn't, in environments where there's not good communication. There are plenty of environments where there are, but the environments where they're not, no one wants each other's job. So why don't we just do what's best for the athlete?
So if I'm a young physical therapist, maybe I'm in school, maybe I just finished school. What's the best way, would you say, for them to get involved on the strength and conditioning side? They may never want to be a strength coach, but what's the best way for them to get more information on what a strength coach does, some of the things that could be integrated with what they do?
I would go to the strength coaches at the school and say, listen, I am a physical therapy student. I am interested in learning what you guys do. They say never use the word never, if you know what I mean, but I have never heard anybody turn down someone that wanted to, especially a student that wanted to learn.
Yeah.
The strength coaches, athletic trainers, physicians, they've all welcomed me with open arms, always. And you have, right? Charlie has. Everybody I mentioned previously. And so if a young student wants to go in and learn, now they may not be hanging out with the football team, right? Yeah. If you're at a big Division I university, you may be with another coach, an assistant coach with a different team, but that doesn't matter. You're starting the process of education. We had something always stuck with me. We had a fellow at the Hospital for Special Surgery, and now he's down at Duke. His name is T. Mormon, and T's a good friend, and he's a great guy and a great surgeon. And I asked T when he was a fellow, I said, in your opinion, what are some of the factors that you need to do to become a great surgeon, right? Because I'll take some of that advice and what can I do to become a better physical therapist, right? And he said, well, I could tell you one thing is that you've got to go to the library and get a callus on your butt. And that always stuck with me. So that's what I mean, being a lifelong learner. So It may not be only spending time with the coaching staff. And I understand you have your physical therapy or athletic, whatever your major is, responsibilities, but maybe go and review some literature with substance that's valid, not nonsense, on the field of strength and conditioning. Look at some things in the history of strength and conditioning so you understand where things came from. And then once you have a little bit of that background, because you got a little bit of a callus on your butt from researching, that's a conversation you could have clinically in the weight room, if you want to call it clinically, in the weight room with the assistant strength coach. And now there's something to elaborate instead of just being spoon-fed. But I think that you have to, in all professions, you have to take the incentive to be better. And you know, if you're not going to take the incentive to be better, why would you ever get better?
Yeah, yeah. And if there's people who maybe want to do something like you and they want to still be a physical therapist but still do some hands-on coaching, you know, what's the best way to do that? How would you, you know, without diluting either side?
Well, I don't think you dilute it. I think you enhance it, right? Because you're going to be a better strength coach because you're more apt to understand the body from the perspective of your training in physical therapy and athletic training. And so you may avoid things knowing that at these periods of time, due to the healing continuum, I am not going to deep squat someone that had a posterior meniscal repair because I know what happens at the knee joint in that deep squat position over these periods of time, right? Versus someone who doesn't know that, thinks someone's 8-10 weeks post-op, it's okay, we'll start to deep squat them. Likely not appropriate. Maybe some people get by, probably not appropriate. And then on the strength and conditioning, so on the strength and conditioning side is, well, wait a minute. I know you don't want me to do X, but we can do Y and get the same effect because these are exercises. It's just like, think at how early in the rehab process, when it comes to mock drills, you can start doing A-walks. You could start doing A-walks as soon as someone is full weight bearing without an assistive device because they're walking anyway. And now you start to imprint that pattern, right? And you're starting to get active range of motion and get that heel back up to the gluteal fold, but you're just walking. If you never had a strength and conditioning background, if you never worked with these track and field drills, you would not be walking your lower extremity patients as part of their rehab program. You know? So it doesn't have to be high stress activities either. And so I think you'd be a better strength coach by being a physical therapist. And I think you'd be a better physical therapist by being a strength coach. What's the trick? The trick is, how do I find a situation where I could do both? Because if you're employed by someone, they're going to want you to work 40 hours a week. And if you're an assistant strength coach, you have to find a part-time position. But you don't have to be at university of whatever. You could be a high school strength coach, and they probably welcome you with open arms. Let me tell you something. If you're a good high school strength coach, you're probably a damn good coach because, as you know, the tools and the resources available at most high schools are sparse, and therefore you really have to be ingenuitive. You really have to have good critical thinking, and you really have to evolve. And I think there's a lot of great college, high school strength coaches that would succeed at any level.
Yeah. Now, if I'm a strength coach and I want to learn more about the physical therapy side, what avenues are there for strength coaches to learn? And understanding that, you know, you don't want strength coaches being physical therapists, but you want them to understand what's involved.
I think you have to, well, if you're an institution, it's easy, right? Because all you do is walk across the hall and try to develop that relationship with your athletic training staff, which you should anyway, and there's usually a team physical therapist, okay? So that's the easiest scenario. If you're in a private scenario, then you have to find someone that's going to be accepted of you and willing to teach you, and I think they would, as long as you maintain your scope of practice, which is what the words I was looking for before, and just explain that you're just trying to have an understanding of what goes on in this rehab process and what's happening with these injuries, because you are eventually, as a strength coach, going to get some of these athletes, and you just want to be a better strength coach and not hurt these people. You want to be able to provide a service that's going to be enhanced versus where you are now. You just want to get better. And why would someone deny someone knowledge and someone who has incentive that just wants to get better in any profession? I don't know many or any who would. And so that's what you'd have to do. I will say this too, especially in the private sector. I think with insurance companies, becoming more stringent on the aspect of providing physical therapy, whether justified or not justified. That's just the way it's going. A lot of these post-discharge patients, athletes or not, are going to need to find individuals, and the physical therapist should realize this, who are going to have have confidence in individuals who are going to be able to have that continuum of care, to bridge that gap until they can return to sport, whether it's the 75-year-old with a total knee replacement that's going to go to their personal trainer and continue to work out so they can play golf, or the 18-year-old athlete that's going to run track, or the 21-year-old athlete that's going to be playing Division I football. And so the physical therapist has a lot to gain by developing a relationship, as well as the athletic trainer with the strength coach, as the strength coach does with them, but also in regards to, for lack of a better term, a business arrangement. And I'm not talking about kickbacks or anything like that. Like, when you're done with therapy, I have a great person that I could base my reputation on that's going to continue to take care of you until you're ready to play, because I don't do that here anymore. You're done with me, and this is the next progression for you. And physical therapists and healthcare professionals should align themselves with those people who are competent and reputable.
Now, I would consider you one of the best resources to discuss all of these topics that we discussed right now. Where are you presenting? What do you have coming up? Are there ways people can see you?
I'm presenting in September, University of Colorado. November, I'm in Boston. December, I'm presenting at the Sports Physical Therapy section in Las Vegas, as well as University of North Carolina. But my email is my name, R. Panariello, Panariello, at our company, Professional, PT, P as in Peter, T as in Thomas.com. And it may take me 48 hours or 24 hours to get back to you, because I'm a busy guy, but I give you my word, I will get back to you. If someone wants to email me with questions or concerns, I'm a big believer in paying it forward, giving it back. All these people I named before, Vermeil, Chu, Parker, Miller, yourself, Charles, they accepted me. They took me under their wing, right? All of you, and taught me. I owe it to them to give back. And that's the one thing I tell everybody I work with. The only thing you ever owe me is, in years to come, you have to have a commitment, not only for continued learning, but you have to have a commitment to give back. And as long as they agree to do that, I'll do for anyone, as they have done for me.
Yeah, we'll publish all your information, and if people want to get a hold of us through the website and provide feedback to you, I'll make sure you get that. And the other thing was, you held a great conference back in May, and you had a lot of these great people presenting, and you guys are going to make that available at some point.
Sure. We'll have that video available at some point as well.
Awesome.
In the near future. Yep.
Awesome. Well, thanks for everything you've done for me, Rob. And
it's a two-way street, Derek. Thank you for everything you've taught me as well. I appreciate it. It's been a pleasure.
Great. Thank you.
Thank you.
So again, that was a lot of quality time with Rob, and I'm sure you got a lot out of it. And if you want to get in touch with him, I'm going to leave his contact information on the website, on the descriptions for the social media as well. And he's somebody, if you're in the New York area, absolutely get in touch with him. Worth every effort, whatever it costs you to spend time with this gentleman. And you can get more information on obviously our website, strengthpowerspeed.com, social media site, Facebook at Strength Power Speed, no vowels, Twitter, Strength Power Speed, no vowels, and also on YouTube. So please, provide any feedback you can. If you're a physical therapy student, athletic trainer, strength and conditioning coach, this man can help you on many levels. So I really encourage you to get in touch with him, and please provide us feedback, and I look to getting you some more great interviews on strengthpowerspeed.com.